So, okay. But I thought you had one program with Dr. Abhishek Mangeshikar also.
We had that a few days back, sir.
Oh, that's done already. I thought that was
Hmm.
going to happen. So, but why so many people for endometriosis? I mean, are you guys researching on it or something of that
Hmm.
sort, or what is the idea behind it?
Actually, we are trying to find a solution to a treatment to endometriosis using synthetic biology. We have a competition called iGEM. For that,
Mm-hmm.
we are trying to find solutions to to endometriosis using synthetic biology techniques, and
Wow.
we do. Hmm. So for that, as part of the awareness campaign about the disease, we were contacting people who can inform everyone because this disease is not very well known. Even when
Absolutely.
we started searching about it, we didn't
Mm-hmm.
have many resources to refer to. So we thought
True,
that it
true,
is
true.
necessary to spread awareness about this disease to make people more
That's
aware.
fantastic. You need to tell me more about this synthetic, whatever you're talking once
Hmm.
our talk is over, okay? Because this
Sure,
sounds
sure, sir.
interesting.
Sure, sir.
So it's good because you have a very few endometriosis specialists in the
Hmm.
country and actually globally also, if you see, and even the doctors themselves, the general physicians and the routine gynecologists are not so well informed about
Hmm.
endometriosis. But anyways, I think you can start off. Yes.
Sure. Good evening, everyone. Welcome to another talk by the IISc iGEM team. Today we have Dr. Hemant Kanojiya. He's a pelvic endoscopic surgeon and the director of EXCELLENDOCARE with us here today. We welcome you, sir, and thank you for joining us. Uh,
Uh, Good evening, ladies and gentlemen, boys and girls. Thank you so much to your institute, the Institute of Science Bengaluru, and especially to Shloak Vatsal for inviting me and giving this opportunity to present my views on endometriosis and thereby creating some awareness, which is much needed in these current times because the disease is, actually increasing exponentially as we are seeing in the last say, 10 to 15 years. Previously, when I was doing my residency, I had not seen so much of endometriosis. Probably because we were missing it out also, and probably because there was not much awareness or education in terms of endometriosis, even amongst us gynecologists and routine general physicians. So I've been involved with endometriosis for the last almost 10 to 12 years, and I've taken it upon myself uh, passionately about this cause and creating awareness. And obviously, I'm an endometriosis surgeon, and thereby form one part of treatment of endometriosis. As you know, endometriosis requires complete 360-degree holistic approach. So surgery can't be the only option, although I am a hardcore surgeon, but there are many other options and we need to explore all these as well as find out some kind of cure, because at the moment there is no 100% cure for endometriosis. It is a chronic lifelong disease, just as diabetes. You can say you can control it but you can't eliminate it, but the awareness in terms of diabetes is just immense. If you see, people know about diabetes, everyone knows about diabetes, there's a lot of awareness, not even 1/10 of it as regards to endometriosis. So we nearly need to work on this together. We doctors can't do it alone, so we need people like you to help us out, the youngsters, the NGOs, the endometriosis advocates. Advocates are those who have been afflicted by the disease and now after some sort of cure, or they're still battling the disease, but they have taken it upon themselves to create awareness about these disease. So let's start off with what is endometriosis. So you might see this kind of a gory picture on your screen, which is actually endometriosis. This is distorted pelvic anatomy. Normal pelvic anatomy doesn't look anything like this, and that is what endometriosis does. It causes and creates havoc and chaos in the pelvis. It totally alters the milieu, the normal milieu inside the pelvis, and thereby causing a lot of reaction, and thereby all this distortion of pelvic anatomy. And the ultimate result of all this is immense pain to the patient, which is the prime reason why we need to see into endometriosis. So again, the question comes is what is endometriosis? So endometriosis is nothing but the presence of endometrium-like tissue Mind you, it is endometrium-like tissue, all the stromal glands, which are actually the endometrium is lining the uterus cavity, the uterine cavity. So endometriosis is endometrium-like tissue, but it is present in a location where it is not supposed to be present. That is an ectopic location within the pelvic cavity mainly. That could be the surrounding area of the uterus and the adnexa, or it could be in some cases, not very common, but extra pelvic also. So in short, let me explain you with this sketch to make it a little easy for you. So if you see, this is, yeah. Is my screen visible?
Yes, sir.
Okay, so if you see, this is the uterus. Okay, this is the mouth of the uterus, also known as the cervix, which opens into the vagina. And let's have a bit of an orientation of the anatomy. Here you have the urinary bladder situated anteriorly ahead. Okay, and behind you have the sigmoid and the rectum, which is also part of the large intestine, which stores the stools before it passes out to the anus. Okay? So if you see, the uterus has a mouth over here. This is the cervix, and this is the entire lining of the uterus. Okay, by lining, I mean there is a tissue over here lining the uterine cavity known as the endometrium. Okay. Now, this tissue cyclically reacts to hormones every month. Now, the hormones that we are concerned with is estrogen and progesterone. Progesterone, right? Okay, so every month this responds to these hormones and grows in a cyclical manner. And if there's no pregnancy, then this endometrium is shed off through the mouth of the cervix into the vagina, and the female gets something what we know as the menses or the menstrual cycle. So this lasts for 5 days, and again the next month the cycle repeats itself, and this goes on. But what happens in endometriosis is this endometrium like tissue, which is supposed to be lining only the uterine cavity, is present outside the uterus. So it could be present here behind the uterus. So this is posterior. If you see, this is the posterior or behind, and that is the anterior. Okay? So it could be present over here in between the uterus and the rectum, or on the rectal wall, infiltrating to varying extent into the rectal wall also and causing symptoms. Or it could be present anteriorly over here in between the uterus and the bladder, over the bladder. Okay. It could also be present within the wall of the uterus. This is the walls of the uterus, which are again muscular fibers, smooth muscle cells. Okay, they are not supposed to be present over here. The endometrium-like tissue might be present in the walls also, which is a condition known as adenomyosis. So adenomyosis is nothing but endometriosis of the wall of the uterus. So if you see now another diagram over here, I'll give you another orientation. So this is the uterus. There are two tubes, the left tube and the right fallopian tube, which carry the egg. Then near it is the left ovary and the right ovary. This completes the uterus, and these are the ligaments of the uterus known as the uterosacral ligaments. So as I showed you in that diagram, here is the bladder. This is another view. This is actually what we see during surgery, this kind of view. That was a cut section what you saw previously. That's the bladder anteriorly. This is the urinary bladder. Sorry, this is the urinary bladder. And this is the sigmoid or the large intestine, which ends into the rectum. And somewhere down the line over here, you have these tube-like structures, the ureters, which carry urine from the kidney into the urinary bladder and pass through the pelvis, or go from the lumbar region into the pelvis right up to the bladder. But their course is here behind the ovary. They are also close by. So if you see, endometriosis can affect this area, as you saw in the sagittal section over here, cut section. Okay, so this is the area which is behind, in between the the rectum and the uterus. It could be over the uterosacral ligament. It could be over the ureters. It could be in this peritoneal covering. Peritoneum is nothing but covering within the abdominal cavity. It could be into the tube, which causes collection of blood known as hematosalpinx. It could be into the ovary, which is a common cause of endometrioma. This is known as an endometrioma. Okay, or it could be anteriorly over here in the region of the bladder, in between the bladder and the uterus. Okay, so this is how actually you see endometriosis into the abdomen. So if I go over here again back to my presentation, that is what this diagram also over here clearly shows. So what are the risk factors? Now, as before the risk factors, let's go to the theories. There are various theories because the exact cause is still not known. E for endometriosis, E for enigma. It's an enigmatic disease. It's absolute puzzle. It was described almost 100 years back, and after 100 years of endometriosis, we still do not know the actual origin or the actual cause of the disease. It is still in research phase. However, there are multiple theories and postulations regarding the origin of the disease. The first theory was Samson, which actually attributed it to retrograde menstruation. So again, if I go back to my diagram over here, the retrograde menstruation is nothing. Suppose this is the lining over here. Okay, this is the lining. And these are the tubes. Okay, the tubes are open to pick up the eggs over here. Okay? So this blood goes retrograde and from this opening into the abdomen, and that is known as the theory of retrograde menstruation. And it is postulated that these endometrial cells go into the peritoneal cavity, get implanted over various areas, and then they behave like endometriotic tissue. But this theory has been, dumped long back, and there is no proof that retrograde menstruation causes endometriosis because almost every female is going to have some form of retrograde menstruation, and not all of them land up with endometriosis. Then there could be transformation of the peritoneal cells known as metaplasia, where the normal peritoneal cells get converted into endometriotic cells, and there are other many causes postulated, but the latest one which I want to highlight, which is not even mentioned over here, is known as the theory of mullerosis. So this was actually coined by Dr. David Redwine, who is a professor in US, a gynecologist. And according to him, all this starts at the embryonic stage, where there is abnormal differentiation and migration of certain mesenchymal cells into the pelvis. These remain dormant over there for quite some time, and due to some trigger or genetic variation, they get triggered off and they form endometriotic cells. There is good amount of research happening in this area, and his theory seems to be the most logical at the moment in terms of manifestation of the disease, but still we don't have a fixed cause. It is up to scientists like you to research on this on a molecular level and try and find out a cause and cure. So what are the risk factors? As we know that it is a condition related to menses. The pain increases during menses. So the more number of menstrual cycles a lady has, higher the chances of having endometriosis. So nulligravitas, somebody who's not had children, somebody who's had an early beginning of menstrual cycle, a late menopause because she's had menstrual cycles for a longer period of time, shorter menstrual cycles, frequent menstrual cycles, and heavy menstrual periods. It is definitely a tissue which is stimulated by the estrogen hormone. So if there is a high level of estrogen in the body, as it is seen in obese people or people with high body mass index, I'm sorry, here it is low body mass, it is actually high body mass index, they have more chance of manifesting this disease. So it's a hyperestrogenic state which leads to this kind of endometriosis. It is definitely seen in relatives and may have a genetic predisposition. There is something known as an epigenetics, which you guys might be knowing much better as budding scientists. Epigenetic is not a mutation, but it is the expression of the gene which is altered due to whatever environmental factors or lifestyle modification. And even that is supposed to be a cause of endometriosis. And any disorders of the reproductive tract, something which is obstructing the flow of the menstrual blood out of the vagina. Suppose there is a septum or some kind of a wall which is obstructing the flow, normal flow of monthly flow of the blood out, it gets accumulated in the uterine cavity and will definitely go out through the tubes. Those patients might have a higher chance of endometriosis. The sites are within the pelvis. It's more common. Extrapelvic endometriosis is not as common. The commonest site is the ovaries, the ligaments, and all along the uterus. So, what are the types of endometriosis? As I told you, it could be pelvic or extrapelvic endometriosis. Pelvic endometriosis is the commonest or the first type, which is the ovarian endometriosis. I showed you the endometrioma. Now, endometrioma is nothing but collection of endometriotic fluid, which is actually chocolate colored. Now, this is nothing but altered blood or altered hemosiderin pigment, because you know blood has hemosiderin. So there's altered hemosiderin pigments which cause this chocolate fluid to accumulate inside the ovary. It actually starts as a superficial endometriotic spot and gets invaginated. So if I can again show you with an animation, it would be really good. So here you can see. So suppose this is the ovary here. Okay. So initially it starts off as a superficial spot and this gets invaginated into the ovarian cortex, and the blood or the chocolate fluid keeps on collecting over here, resulting in a proper cyst. Or cyst is nothing but collection of fluid within the ovary. It's known as an endometrioma. Okay, so this is what chocolate cyst or an endometrioma looks like. So here you can have the peritoneal affection. I told you peritoneum is nothing but the covering into the abdominal cavity, which is known as the peritoneum. Okay, so this peritoneal endometriosis could be superficial, where the invasion is less than 5 millimeters, or deep, where the invasion is more than 7 millimeters. That is why it is called as deep infiltrating endometriosis. And then extra pelvic, it could be on the intestines, it could be in the urinary tract, be on the scar of an abdomen. So suppose a previous cesarean has been done, the abdomen has been incised. Okay, the baby has been delivered out from the uterus, not from the vagina, but from an abdominal cut. And subsequently, that incision or wound can develop scar endometriosis, probably because of implantation of the endometrial cells, or the same theory what we had explained earlier. And there could be endometriosis in the lung. There have been rare instances reported of endometriosis in the cerebrum or the brain. So what is the clinical presentation of these patients? There is a lot of signs or symptoms which are there, but the main one is pain in abdomen. Okay, it could be a deep pelvic pain. Now, normally this pain is of various types, of various intensities. Some describe it as a dragging kind of a pain. Some describe it as a pain in the abdomen accompanied by backache. Some have even described it as pricking kind of a pain, or a pain which is going into the lower limb. This could be any kind of a pain. There's no specific kind of a pain which points towards endometriosis. Then there is painful periods. This is a very important sign in young girls, because they normally in early stages they present with heavy or very painful periods. Okay, now the question amongst the general or the lay people is that some amount of pain is expected with almost 100% females during menses. So how do we make out, that this pain is due to endometriosis? It's very important to remember. These are one of the red flags of endometriosis, because there is no screening test for endometriosis at the moment where you can screen a cohort or set of patients who are at high risk, and filter out the high risk for endometriosis, or those who are already affected with endometriosis. So The pain has to be quantified in some form. So we have various visual analog scores, as you see over here, scoring the pain from 0 to 10, depending upon the intensity of the pain. So we have various visual charts and analog score where the patient can probably quantify her pain. So any pain which is more than say 7 to 8. The other red flag is any pain which affects the routine daily function of the female. So if they are adolescent group, there is lot of absenteeism from the school due to the pain, or she can't really carry out her routine functions. The pain is just immense. She's just rolled in bed and not able to do anything with that kind of pain, excruciating pain. These are red flags and should be further investigated and not just brushed under the carpet as a routine thing which needs to be tolerated, or one needs to carry on with this. Then dyspareunia, dyspareunia means painful sexual intercourse. So as you know, endometriosis affects the area between the uterus and the sigmoid, and there is stretching of the ligaments during intercourse, and that fibrotic tissue really causes pain. So these are mainly the symptoms. The other symptoms, if the urinary bladder is affected, there could be painful passage of urine known as dysuria. There could be painful passage of stools known as dyschezia. If the bowel is affected, there could be constipation or altered bowel habits like constipation coupled with loose motion because of some form of obstruction in the intestine due to invasion of the endometriotic tissue. Then there could be excessive bleeding also. These patients are sometimes affected with adenomyosis, as I told you. That is endometriosis within the wall of the uterus. So it does cause painful periods also. And an important cause in those who are in the reproductive age group or who are married, endometriosis is an important or a very important cause of infertility, where they are unable to conceive even after having unprotected sex for say more than 1 year. Okay, so that is known as infertility. So at least 50% of patients of endometriosis are going to have infertility, and those suffering from infertility, 30 to 40% are going to be having infertility due to endometriosis. So it's an important correlation between the two. Now, why does endometriosis cause infertility? Because it completely distorts the pelvic anatomy, as I showed you, and I show you again over here. So between this is the normal relationship between the tube and the ovary. So if this gets distorted due to these things getting stuck up to each other, that is known as adhesions, there is going to be a distortion in the pelvic anatomy, and that's why the fallopian tube over here can't pick up the egg, and that's why there is a problem in conception. Also, there is a problem in implantation of the pregnancy at the level of the endometrium. As I told you, the entire milieu changes inside. Also, as we discussed, there is adenomyosis, which again causes implantation problems. So now coming to the bowel endometriosis, which I told you. So suppose this is the bowel over here. Okay, so endometriosis could be just superficial on the bowel, or it could be infiltrating the layers of the bowel and causing an obstruction of the lumen of the bowel. And that's why it causes painful passage of stools, or even constipation or altered bowel habits. Even if you see over here, this area, the bowel is pulled up towards the uterus, and there is some form of kinking and altered axis of the bowel. That's why there is also the reason of dyschezia or painful passage of stools. So now coming to what does endometriosis do? I told you that it is a chronic inflammatory tissue. So what happens is this endometriotic tissue undergoes repeated wear and tear, okay, with inadequate repairing in between. So what happens is this cycle of chronic wear and tear goes off, because of which a lot of inflammatory substances are released. This inflammation really leads to some form of fibrosis, which is nothing but thickening of the tissues. Okay, now this thickening of tissues causes entrapment of the blood vessel, the nerve fibers, and that is why the patient gets so much pain. And that's why this is important. This fibrosis is important, and that is what we do surgically. We try to remove all this visible fibrotic tissue so that the load of the disease decreases. So now coming back to our slides. Okay, so symptoms I think we have discussed. Now, how do you diagnose uh, endometriosis? Come to that. So the diagnosis can be through imaging. Okay, so you have MRI or an ultrasound, USG. These are the two modalities which can help us in picking up endometriosis. Ultrasound is as good as MRI, a cheaper option, but we need trained people to pick up endometriosis properly on this, because normally the radiologists are not trained just to pick up endometriosis. It has to be a focused, sort of a branch where a radiologist is trained to pick up endometriosis, because it's not easy to interpret the images so easily for a routine radiologist. And MRI is much better because the images are quite standard, but the reporting is also important. So again, the radiologist needs to pick up those, changes in the intensity of the image and pointing out towards endometriosis. So these are the two modalities of investigation. So again, I will touch upon the red flags of endometriosis. I told you about the chronic pain in abdomen. I told you about the affection in quality of life, which is very important and which is a great red flag which needs to be investigated further. Now, what are the treatment options that we have for endometriosis? Okay, the treatment could be medical management or it could be surgical management. The basis of medical management is to suppress the hypothalamic pituitary axis. We all know there is control or a remote control button in the brain which forms the hypothalamic pituitary axis and which has a direct effect on the uterus and the ovaries to secrete hormones like estrogen and progesterone cyclically during the menstrual cycle of the female. So when the entire, and we know the endometriotic tissue is responsive to estrogen. It is an estrogen dependent tissue. So the idea or the basis of medical therapy is to give hormones externally. By negative feedback, they can suppress these hypothalamic pituitary axis and thereby reduce the internal estrogen and progesterone, similar to something what happens in pregnancy. So in pregnancy for 9 months, the entire axis is suppressed. There is no menses, only the pregnancy is growing. So something like a pseudo pregnancy state is created where your menstrual cycle is stopped and the estrogen levels are down, and thereby it gives some relief from the endometriosis symptoms by suppressing the endometriotic tissue. But the problem with medical treatment is that the moment you stop this medicine, the symptoms can come back because the endometriotic tissue again reactivates itself. And the problem with endometriotic tissue, the deep infiltrating kind, is these are autonomous cells. Okay, they are self-propagating cells. They are known to for clonicity. They are autonomous cells. They secrete their own estrogen, mind you. So even if you are going to suppress it on outside, they can grow because they have the capacity autonomously or autologously to produce their own estrogen, and they're self-propagating. So actually, if you see, these cells are a bit similar to cancer cells. We can't label endometriosis as cancer because it is definitely a benign disease. The behavior locally, at least, is like cancer because it invades the surrounding local tissues, as we saw the rectum, sigmoid, bladder, the other surrounding tissue like the tubes and the ovaries, or even outside the pelvis. So it does have an invasive nature, but it does not metastasize like cancer through the lymphatics. As of now, at least, it is not proven. And the major difference between endometriosis and cancer is that cancer is a catabolic condition, okay, where the cancer cells, take energy from the body itself. It's a catabolic process. At least endometriosis doesn't do that, but it is definitely a locally invasive disease. And that's why we need to have a kind of radical, aggressive approach towards the treatment of endometriosis. Now, by radical, I mean surgically excising as much tissue as you can, when the indication arises. So let me discuss with you now what are the indications for surgery, or when do you opt for surgery. For that, we need to understand that the manifestation of endometriosis is quite varying. As I told you, it's a complex, enigmatic disease. It is graded into various types, grade 1 to grade 4, depending on how much distortion or how much depth of invasion is there. So grade 1, grade 2 are mild, grade 3, grade 4 could be termed as moderate to severe. So in grade 4, the entire anatomy is distorted and there is deep infiltrating endometriosis. The problem with endometriosis is a mismatch between the grade and the manifestation of symptoms of the patient. So you could have a patient having grade 1 endometriosis, okay, as you see on the findings on imaging, or probably on a laparoscopy where we put a scope inside to see the inner side or the inner abdominal cavity. It could be a grade 1 where the patient is having immense pain, or you could have a patient who is not so symptomatic and a scope is put in for some reason. Say she is infertile, not conceiving. You put in a scope and you see grade 4 endometriosis. So that is the dilemma in the minds of the clinician or the surgeon, because there is a mismatch in the manifestation of the symptoms and the findings. So still there is not a clear-cut consensus and guidelines as to the treatment. So what we follow is a tailor-made, customized approach to the patient when treating them for endometriosis. So the entire crux or the core of endometriosis is that it should be a symptom-centric treatment depending upon the symptom of the patient. That's why it's very important to quantify the pain in the abdomen, the amount of dyspareunia or pain during intercourse, the amount or the quantification of pain during passage of stools or while passage of urine. So this all needs to be quantified. So can I switch on my camera now, Shlok? Because the
Sure, sir.
slides are over, and just let me know when we are into, say, around 20-25 minutes. How many minutes are we into?
It's been around 20 minutes, sir.
Okay, so we'll try and end it in another 5 minutes. So am I visible on the camera? Because I'm not sure whether I'm visible or not. Am I visible on the camera?
No, your camera is turned off, sir, right now.
No, but I can't switch it off because I think I need some permission to, because it's just showing a cross and I'm clicking on it. It's not happening. Anything you can do about it?
No, sir, I think all the permissions have been given. It might be
Local
it might be
problem.
possible that the screen share and the
Ah,
camera is
screen
not
share.
working
So
simultaneously.
can I stop my screen share then?
Sure, sir.
Video share photo. How do I stop my screen share?
The same button, sir.
Yeah, but it's showing share video, share camera.
Your screen share is off
Ah,
now,
yeah,
sir.
yeah, yeah. It's off, right?
Yes, sir.
Yeah, I think now I am visible. Okay, am I visible now?
Yes, sir. Now you're visible.
Right. So we were talking about the treatment options. So it should be a symptom-centric, customized, tailor-made approach to the patient depending upon the age of the patient, the amount of symptoms that the patient has, the goal of the patient, whether the patient desires fertility or children now or no, okay, or what is, in terms of whether she is above 40 and she wants everything out, including the uterus. So normally, if it's a young patient, the first line is always medical treatment, but we do give a trial of medical treatment before proceeding to surgery. But once the diagnosis of deep infiltrating endometriosis is made on imaging like MRI or ultrasound, and the patient is very symptomatic, it is definitely better to operate and improve her quality of life. Now, by surgery, we mean we have to radically excise all these endometriotic fibrotic tissue on whichever organ they are affected. But at the same time, we follow an economical approach because we know this is not cancer. Okay, we know this is not cancer, so we need not be so radical, because sometimes if you operate for cancer, you really don't bother about the function of the organs because you want to get totally rid of the disease. Okay, there's no choice that you can, leave some cancer behind. But in endometriosis, you have to debulk the disease or reduce the load of the disease in an optimum manner, at the same time maintaining the function of critical organs like the bowel, the ureters, the tubes which I showed you, or the bladder, because you can't sacrifice them so much so that the morbidity of the patient or the patient suffers after the surgery. You just need to improve the quality of the life of the patient and not really deteriorate the quality of the life of the patient after surgery. So it is something called as what we term as economic radicalism. Okay, we follow a radical and aggressive approach towards the disease, that is endometriosis, but we are economic towards the function of critical organs so as to they can function properly after the surgery. A major part of this is saving the nerves which supply these organs. Because if you're going to do radical excision of the disease, you might damage the nerves, and then the patient might have problem, in having a sensation of passage of stools, or might not be able to evacuate the stool so easily, or might be having urinary frequency problems, or the bladder can't really hold on to too much urine. Okay. So these are some things which we are in a gray zone, and there's no clear cut this about how much to remove or how much not to remove. It does come with good amount of experience and good volume of cases, but the entire crux of the matter is to improve the quality of life. And as I told you, it is a chronic condition, so we can't make the disease zero. We can debulk it or make the load of the disease less, so that we can put her on medical management later, but there could be a chance of a recurrence. We have to remember that. So maybe the recurrence might be around uh, 50% or 40 to 50% after 5 years. And but the thing is, now who should be doing an endometriosis surgery? Okay, should it be a routine gynecologist? Should it be a cancer surgeon, because they are used to more of these radical surgeries? Who should be doing it? The right answer is the surgery should be done by an endometriosis excision specialist. Now, what is an endometriosis excision specialist? It is basically a gynecologist who has a special focus and special interest in this area, who is passionate about this and has dedicated good amount of time and developed good experience in managing these cases, because the results are much better with these experienced surgeons. Obviously, it also requires a multidisciplinary approach. Like, it's not only the gynecologist, but the help of a colorectal surgeon, because the intestine can be involved. A part of intestine might have to be removed and stippled to rejoin it. A part of bladder might be removed, or a part of ureter might have to be rejoined or reimplanted or stented. So we might need a urologist also. So it is a multidisciplinary approach, but the person who's in charge is the gynecologist, or as you have heard this term, as a pelvic endoscopic surgeon, who is comfortable operating in the pelvis and is very much oriented to all the organs within the pelvis of the female. So these are mainly the things what I wanted to highlight. One important thing before I sign off is the gaslighting of symptoms. Now, gaslighting is an official medical term where the symptoms and the manifestations of the patient, the complaints, are basically neglected. They are sort of looked down upon, or sort of dismissed, that it is mainly psychosomatic, it's not really so much, or you need to live with this. And this is not only with the society or the routine people doing this to the patients of endometriosis, it is even seen amongst physicians and even amongst routine gynecologists. the myth usually is that you're a female, you're supposed to have periods, you're supposed to have pain. But that's not the situation. The situation is that she has immense pain. It is affecting her quality of life. And if you're going to sit upon this, the disease is a progressive one. It progresses over a period of time. In adolescent females, it is seen that more than 60% will progress to the next stage. Another 20-30 might remain in that stage, and less than 10% it might decrease. So you can see how many of them go to the progressive stage. And the most important thing about this disease, the reason that it causes so much problem and so much distortion of pelvic anatomy, is that the diagnosis delay on an average is 8 to 10 years from the beginning of the symptoms to the last diagnosis. That is again because the patient runs around from pillar to post, being misdiagnosed. It's normally, diagnosed as just, sort of an inflammatory bowel disease or some other chronic problem, which and endometriosis is totally neglected. And then it progresses on to a severe form. So I think this is what I need to communicate as far as students and the general public need to know about endometriosis. I hope I made myself clear and I, justified these 20 minutes by putting my point across. And I just hope this really helps in creating awareness amongst you guys, because you guys are the future scientists. And as far as my request to you goes, that you need to really research on this at a molecular level, because everything in endometriosis now is happening at a molecular level. They're trying to find out the molecular cause and how they can deal with it at molecular level. As you said, you're talking about synthetic biology. So tell me now more about the research that you guys are doing. I think I'm done. So are you guys okay with what we discussed or what I said?
Thank you, sir. That was a wonderful talk. It reminded me of my bio classes, the way you explained everything through those diagrams. So
I
what
hope it
we are
really
trying.
helps.
So what we are trying to do is we are producing certain mRNAs that would go to the
Mhm,
cells that are causing endometriosis and would
mhm.
produce anti-IL-8. So we found out during our research that IL-8 was something that was causing the inflammation. So we are trying to counter that using a protein called anti-IL-8. So that's
Mhm.
what we are going to produce inside the endometriotic cells.
But from what I understand, there are multiple inflammatory things that are released in an endometriotic tissue. There's interleukins, there's prostaglandins, there's a lot of things and a lot of names that you all know. So is a specific thing really going to prevent that?
So during our research, we found out that it has been proven that these IL-8 is actually interleukin 8 only. So we
Yeah,
found
yeah.
out that this was actually this was proven to be reducing the inflammatory part of it. And that's
Okay.
what we uh, thought of as our primary target to counter endometriosis.
So you
So
have some background literature on this, or this is your own finding?
we have some papers, and I think a better person to answer this would be our team leader. I request
Please.
Aditya to please clarify this a bit more.
Hi, good evening, sir. Um,
Hi, Aditya.
yeah, so basically the reason why like we thought of interleukin 8 specifically is
Mhm,
because as I went through like quite a few papers, as to what cytokines were affecting the progression of the disease,
mhm,
what I noticed is that for like specific interleukins like interleukin 6, interleukin 10, there was very contradictory evidence
mhm.
as to whether blocking or promoting this particular factor would help in like improving the disease condition.
Okay.
But for interleukin 8, I could not find any contradictory evidence at all. And
Ah,
in fact, there's a paper published in Science not last month, in February,
okay.
that actually shows that blocking interleukin 8 locally
Mhm,
in endometriotic tissue,
mhm.
it actually reduces the endometriotic tissue volume by up to 60% over a duration of 6 months of administration of this antibody in monkeys.
Okay. No, my next question to you, I would like to interrupt over here. It reduces the volume. Okay. The problem is it's going to reduce the volume the moment you stop it. Okay. There's a high chance that it's going to come back. So then we are not really looking at a permanent suppression, right? We're just looking at a temporary solution, which we already have, sort of. I mean, I don't know what your basis is. Yours must be something else, but I'm telling you what the current treatment do. The current treatment just suppresses the hormonal axis. It's not at least acting at a molecular level. It's just acting at the hormonal level, and it's suppressing the tissue, but it comes back. And I told you one more thing, that these tissue produce their own estrogen. Okay, so you're talking from tissue inflammatory point of view, which really makes sense actually and fits in the logic. But is that suppression complete, or it's just, so permanent, or it's temporary? That remains my question.
Yeah, so like I was searching for something that would be more permanent than what we're aiming to do. But
Yeah.
what I could find or what I couldn't find is that unless we completely elucidate the perfect cause for endometriosis, which hasn't been done yet, we can't really come up with a permanent solution.
So
So
it's like the chicken and the egg phenomenon, which came
yeah,
first, kind of. Yeah. And that's
so
that's the problem with
yeah,
endometriosis. But believe me, it's a worse disease. It's the most complex surgery. It's the pinnacle of complex surgeries because we do it quite often. And believe me, it's I just this morning I did a complicated case, and it can cause a lot of injuries inside when we are operating also. So we have to be very careful. It's much more complex than cancer surgery. Believe me, cancer surgeons can't operate on endometriosis because cancer, when it is operable, is quite easy to operate. When it is inoperable, they anyways put them on chemotherapy. They don't operate because it's inoperable, right? But endometriosis is complete distortion. All the landmarks what we normally follow while operating are distorted. So it's very high risk surgery. It's at least 4 to 5 times higher risk than a routine case. And if a beginner is doing it, the risk is 8 to 10 times. You can imagine how risky the surgery is. And the risk is so much that it can cause permanent morbidity, permanent
yes,
effects, permanently affect the quality of life of the patient. It can happen that way also. So it's very mind-boggling for us also how to treat this, because we really have to on table sometimes exercise wisdom or exercise our decision, what we need to do. So I hope in the next probably 5 to 10 years we can come to some conclusion. But the Western guys are also doing a lot of research on this, and I'm sure you guys at the Indian Institute are going to do absolutely amazing job. I'm
thank you,
confident
sir.
because all of you are amazing budding scientists, and I have a lot of hopes from you guys.
Thank you, sir.
But and I'm very glad you guys looked into endometriosis, because when Shlok contacted me, I knew Indian Institute of Science is the premier institute. Just today, I was hearing the ranking. It's the first ranked university, ranked number 1 in the country as a university. Yeah? As an institute, one of the IITs, but as a university, I think IISc is on the top. So I'm
Yes,
I'm really glad, and it's really nice to hear that you guys have taken this upon yourselves to research on endometriosis, which is a really bad disease. It's a curse. It's really a curse, because we have seen young girls, college-going girls, some of them just in their 10th standard, also 11th standard, suffering from this disease. You won't believe it. Last month, I had a doctor who was from Hyderabad who I was operating for the fifth time. She's just around 26, 28. I was operating for the fifth time. She's not even married. It really causes heartache, to see these kind of patients. But we really need to work on this, how we can deal. And this is not only an Indian problem. This is all over the world. It's causing, and nowhere the progress is seen. So everyone is just
yes,
into
sir.
the research phase. So I wish you guys the very best. And if there's any questions anyone would like to ask from the medical or the surgical point of view, I would be glad to answer for the next 5 to 10 minutes before I sign off. Please, any one of you on this the broadcast. And if there are
So,
no
sir,
questions, there can be only two reasons: that nobody has understood anything, or everybody has understood everything. Okay.
I think, sir, the explanation was so good that I hope that everyone has understood the things. And actually, we have a question from Sheesh.
Yeah.
What can be the negative effects of these surgeries? What can be
Yeah.
as you explained, the possible risks associated with it? So, what can be the
Yeah.
negative
So
effects
so
of these surgeries if
so
not
I told you, when
performed?
it's deep infiltrating, it's affecting the ureter, which is carrying urine from the kidney. So it's a critical organ. It's affecting the sigmoid, which is part of the large intestine, the rectum, which stores the stool on the last way out, the bladder. These are all critical organs. So when you try to remove the disease from these organs, and you have to remove it because there is painful passage of stools so these organs can get injured. Now there is a way to repair these organs. That's not that we cannot manage the situation, but the surgery itself can land up the patient with complications, especially if an inexperienced person is doing it. Okay, so suppose there's an intestinal injury, okay, or there's intestinal endometriosis, which is invading the sigmoid. We have removed that part, we have staples to rejoin them, but there could be a leakage from that staple line, okay, which has at least a 1 to 2% risk. So out of 100, at least 1 to 2% can leak, which is a very big thing. The stools leaking into the abdomen is a very bad thing. It can cause septicemia, generalized infection, and patient can have mortality up to, that is, patient can die in almost 20 to 30% of the cases. This doesn't happen so often, but that's a collateral damage kind of thing. If the ureter gets damaged, there could be an abnormal leakage of urine somewhere. So these are the things, because see, in a routine surgery we don't touch these organs because everything is free. They are not coming in our way, so why would we touch them? But in endometriosis, they do come in our way. We have to deal with them, and when we deal with them, there is a chance of injury. However experienced you are, there is a percentage. Today I'm doing endometriosis for 12 years. The chances are less. It's like Virat Kohli. You can't have 100 in every match, but the probability of Virat hitting 100 is more than the last or the 12th batsman, right? It's something like that, but still he can get out on zero, right? So it's matter of probabilities and experience, nothing else.
Thank you, sir, for the insightful discussion that
Thank you.
you also did with her, Aditya.
Thank you.
We would surely take in your feedback and try to improve on our project as we go along. We have some
Yeah.
time till the final submission. I would
Right.
also like to thank everyone for joining us here today. We'll
Thank
be
you so
taking
much.
a break for some time for our NSIMs, but we'll be back soon with another informative talk. Thank you again, sir.
Shlok, before you sign off, I just want to ask you, where do you get this endometriotic tissue for your research?
Uh,
Where do you get it from?
we are trying to procure it from a standard cell lining.
Okay. No, is there some doctor who gives it to you who is doing endometriosis surgery, or a pathology lab with whom you have a tie-up? Where do you get these endometriosis cells where you research on? I think you're doing it on the cell, right? On the tissue,
Mhm.
right?
Mhm.
So just out of curiosity, I'm asking you, okay, how do you get these tissues?
I think we are procuring it from from a company which produces these endometriotic cell lines.
There's a company which produces endometriotic cell lines. Okay, it's not the actual body tissue.
Yeah,
Aditya,
sir, what we're doing is,
Uh,
because first of all, for the purpose of this contest at least,
mm-hmm,
actually obtaining a human tissue, endometriotic tissue
yeah,
straight from the source, will actually
yeah.
involve a lot of to be honest, a lot of
Ethics,
paperwork for us. Yeah, ethics and paperwork.
ethics comment. Yeah.
Yeah, so what we're planning to do actually for the purpose of testing our therapeutic is
Yeah.
actually designing an organ on a chip model for endometriosis.
Ah, okay.
So for that, we're actually acquiring two different cell lines from one Canadian and one American company.
Okay.
And we're trying to simulate endometriotic tissue in this organ on a chip system so that we can test the drug without having to actually acquire cells.
Okay. And now it's clearer to me, because I was just wondering, okay, how you're doing your research. What's the foundation? But fair enough. Thank you so much, guys. Really nice interacting with you guys, and I hope to see you guys in person soon, probably. All the best to you guys with your research and with your course.
thank you, sir.
Bye bye.